So at the heart of the human impacts work that we've been doing is trying to help the public understand the challenge it is to administer a safety net healthcare system, given both the financing of that system and some difficult to understand restrictions that the state and federal government put on the actual operations of healthcare service delivery. Remember, when the ambulance comes or when you walk into an emergency department, we don't have the luxury of asking, are you insured, or who's paid for it? The county is the ultimate safety net, and I'm very proud to work for a county that sees healthcare as a basic human right, not to be diminished or, in fact, frankly denied based on your immigration status or the color of your skin or how much money you make. So specifically, the state played a very funny trick on the Affordable Care Act. It's hard to understand, and it's buried in a very complex law that we've been digging at. It's known as AB 85. And what the state did is it claimed that local jurisdictions were going to get a lot of savings because there were now a whole bunch of people newly covered. And in fact, the state projected such savings in advance and took them before they were even achieved. In Alameda County, that's actually going to mean initially this year the loss of $11 million over 6 months, and next year the loss of $44 million for our safety net. Now, those are big numbers, right? But in a healthcare delivery system that's billions of dollars, you might think, okay, we're going to make it. But the key is to look at where those things are targeted, because they're not targeted at the people who live in Piedmont, right? They're targeted at folks who are brown and black, and many of whom do not have immigration status that allows them to be eligible for federal funds. So for this board, for Alameda County, to continue to offer healthcare as a basic human right, it had to recently pledge $9.4 million of new county cost just to provide access to primary care for Alameda County residents who cannot prove current citizenship status. It's a unique and frankly rare commitment from a local government. I'm not sure that it's been done anywhere else. Again, I'm very proud to work in a county that did it. So the human impacts of the state's projected savings on the Affordable Care Act actually required one of the biggest new investments of local funds from this Board of Supervisors that has ever come to pass. And that was actually, that's in our maintenance of effort budget, and I'm grateful for Supervisor Chan's support. The second thing to understand about the human impacts of the state budget on the healthcare delivery system is the question of rates. So remember, Medi-Cal, and in your county, the vast majority are in the Alliance, receive rates significantly less than their commercial competitors. So it's difficult to attract providers to see our patients at the rates we pay. And this challenge is one that we fight all the time with the state. In fact, as you well know, 24,000 seniors and persons with disabilities moved into our managed care system last year. A huge change. Well, the state underpaid us dramatically. In fact, the state has already agreed that they underpaid us by $6.8 million and had made that payment to us. Only in arrears, by the way, right? So we had to pay out. And we have a hearing in July where we're going to request another $25 million in what we believe is actuarially or cost-based reimbursement that we can prove these patients required. So as the state moves its safety net system into managed care and provides rates, it's essential for the local advocacy community and our local electeds to understand how much money we're getting to do what, and compare it to the real cost of doing business. The last thing I'll close on is I was really pleased to see that Seth disaggregated almost all the numbers based on race and class. So one of the challenges we have is just because people like me can sit in an office and show you a benefit for almost every problem, but that doesn't mean you can get at it. So one of the challenges we have is building a geographically dispersed and culturally relevant system of care that people who may not speak English can access. 60% of Highlands patients last year are limited English proficient. Less than half have a high school diploma. We have to develop service locations where people who don't speak English or are new to accessing public services can go get care and help navigate an often complex and categorically funded public sector. Thanks.